I welcome you along with my co-chairman, Dr. R K Jha and Dr. Ashish Dengra. Dr. Manoria is a well-known cardiologist of our India. He is past president in the API, ICC, CSI, and many organizations. He is past chairman of Hypertensive Society of Asia Pacific Society of Cardiology. He was president of the SARC Cardiological Society. He received many prestigious awards and orations like Lifetime Achievement, WCCP 2008 by Bharat Ratna Honorable Shri APJ Abdul Kalam. He also received so many prestigious awards. Organized first World Congress in Cardio-metabolic medicine in 2010. He has edited 33 books and 65 publications in various noted journals. He delivered so many talks, more than 500 lectures in various national and international seminars. I welcome Dr. P C Manoria to talk over a very important topic, that is metabolic obesity, a new therapeutic horizon target for the cardiometabolic risk. I will request Dr. P C Manoria to deliver his talk.
So for the next 15 minutes, I'll be talking on this interesting and upcoming topic, metabolic obesity, a new therapeutic target for cardiometabolic risk reduction. All of us know global prevalence of obesity has nearly tripled since 1975 and continues to grow at an exponential rate. Cardiometabolic diseases are rocking the entire world and are important contributors to cardiovascular morbidity and mortality, and there is an urgent necessity for a cohesive approach to tackle cardiometabolic diseases. It is very important to realize that obesity, particularly metabolic obesity, is always associated with conglomeration of adverse cardiometabolic profile risk factors. On one hand, it is a driver of diabetes, and on the other hand, it is a driver of cardiovascular disease. And all of us know, once you develop diabetes, diabetes is also a driver of cardiovascular disease. And therefore, metabolic obesity should be targeted at the earliest. And it is said that if we could prevent obesity, type 2 diabetes would become rare. So important is metabolic obesity. Obesity is never cured, it only undergoes remission, and that should be realized. How do we diagnose the cardiometabolic risks? It is very simple. You have to just measure the waistline and the BMI. For the Indian context, waistline less than 90 is considered normal for male, less than 80 for female. If you have a normal waistline and a normal BMI, which for the Indian context is less than 23, the cardiometabolic risk is least. But even with a normal waistline, if the BMI increases, then it increases your cardiometabolic risk. On the other hand, if to begin with, you have increased waistline, as you can see here, even if it's a normal BMI, you have increased cardiometabolic risk. And if the BMI further increases, the cardiometabolic risk increases further. For the Western population, the criteria are a little different. The normal BMI for males is less than 40 inches or 100 centimeters, and for females, less than 35 inch or 89 or 90 centimeters. The criteria for BMI are also different for the Western population. The normal BMI is less than 25, overweight, 25 to 29.9, and obese is more than 30. And we have three classes of obesity. Obesity class 1, 30 to 34.9, class 2, 35 to 39.9, and class 3, more than 40. How do we measure waistline? I think all of us are aware of, and I'll skip this. Now, this is a very interesting slide. This slide shows the past president ADA and Dr. Yagnik. You can see BMI are normal. Both have BMI of 22.3, but look at the body fat. Indians have a tendency to have more visceral fat, 9.1% with ADA president and 21.2% with Dr. Yagnik. You can see the discrepancy. The visceral fat is 2 times more compared to the Western population, and that's why we say thin fat Indians or non-obese metabolic syndrome. How do we quantitate our metabolic obesity? This can be easily done on a CT or MRI. Excess visceral fat more than 130 is considered to be increased. On the left side of the slide, you can see excess visceral obesity, visceral fat area more than 146, subcutaneous fat area 115. On the right side, you can see subcutaneous adiposity. The visceral fat area is 60 and the subcutaneous fat area is 190. The pathogenesis of obesity all are clear: high energy, food consumption, physical inactivity, genetic predisposition, gut microbiota implantation still under the process of evaluation, and consumption of high energy foods and physical inactivity is the basic cause. There is a tendency to upsize the food, as you can see. Fat kids with all these foodstuffs, TV cola culture, internet culture, and look at the gross level of physical inactivity. He's taking doggy for the ride, but instead is a vehicle. And the other person in the lower half of the slide is sitting and his doggy is doing a treadmill test. Although obesity is very distressing, but we now have 3 bigs for treatment of obesity. The 3 bigs are drugs, endoscopic bariatric procedures, and bariatric surgery. Lifestyle modification, of course, is an integral part of all therapeutic strategies. Now, these are the FDA-approved drugs for obesity, and except semaglutide, all these 4 drugs decrease body weight by 5 to 10%. What are the 3 bigs in anti-obesity drugs? Semaglutide, tirzepatide, and cagrilintide. So first, let's see about the GLP-1 receptor agonist. Semaglutide is superior amongst all GLP-1 receptor agonists. It is better than liraglutide and, of course, better than oral semaglutide. The rough decrease in weight with liraglutide is round about 6 or 6.5. With semaglutide, I'll show you the data, up to 15 kg or more. Oral semaglutide is only 5 kg. Now, this is a head-to-head comparison in the STEP trial, semaglutide versus liraglutide, and you can clearly see the reduction in weight with semaglutide is minus 15.8 compared to 6.4 with liraglutide. So semaglutide is distinctly superior, and whether you want to look at the reduction in weight more than 5%, 10%, 15%, sometimes even more than 20%, Sema scores over lira. Semaglutide has been extensively investigated in the STEP trials. As you can see, STEP 1, 2, 3, 4, 5. The dose of semaglutide is gradually increased from 0.25 to 2.4, which is the maximum dose. And these are the results of the STEP trial. Step 1, reduction in weight to the tune of minus 14.9% at the end of 68 weeks. Step 3, 16% at 68 weeks. In step 2, at the end of 20 weeks, it was 10.6. And when extended to another 20 weeks to 68 weeks, it is additional 7.9. So tremendous weight loss with semaglutide. Oral semaglutide across the Pioneer program, it is 5 kg. All GLP-1 receptor agonists increase satiety and reduce hunger. via neurons in the arcuate nucleus. The second blockbuster, the second big amongst the big three anti-obesity drugs is tirzepatide, still undergoing evaluation, not yet approved for treatment, but very likely to be approved this year. Is a dual GIP-1 GLP receptor agonist, and it is extensively investigated in the SURPASS trial and also in the obesity dedicated trial, the SURMOUNT trial, and the NASH synergy trial. This is an overview of the all 5 SURPASS trial, and you can see the reduction in HbA1c is to the tune of 2.59% with the maximum dose of 15 milligram. Very great reduction. The reduction in weight across the SURPASS trial, you can see from 9.5 to 13 kg, which is indeed a great achievement. And SURPASS cardiovascular outcome trial is also ongoing. 12,500 patients, diabetes and confirmed ACVD, tirzepatide, 15 milligram head-to-head with dulaglutide, 1.5 milligram. The primary endpoint is cardiovascular death, MI, and stroke. The third blockbuster amongst the anti-obesity is CagriSema. It is a once-weekly combination of cagrilintide, 0.16 to 4.5, plus a fixed dose of sema, 2.4 for obesity and NASH. And cagrilintide is a synthetic, stable, lipidated, long-acting amylin analogs. It slows gastric emptying, suppresses postprandial glucagon secretion, regulates food intake through centrally mediated appetite modulation. And a recent study found that once-weekly CagriSema resulted in a weight loss of as much as 17.1% without lifestyle interventions. We always advise lifestyle intervention, but this shows the magnitude of weight reduction with CagriSema. And if approved, this would be a great molecule and will be in comparison with endoscopic or even bariatric procedures. And this is the CagriSema data. You can see reduction is 17% with 2.4 milligrams. This is phase 1B study with CagriSema, and again, you can see reduction is to the tune of 17.1%. Research in anti-obesity drugs continues unabated, and in future, we will have the triple combination of glucagon, GLP-1 and GIP, and peptides conjugated, as you can see on the slide, may become the golden therapy against obesity, and they act in diverse mechanisms, as you can see on the slide. What are the 3 bigs in endoscopic bariatric procedure? The 3 bigs are intragastric balloons, sleeve gastroplasty, and nutrient diverting therapies. And this shows the details of the endoscopic bariatric procedures. The intragastric balloons and the endoscopic sleeve gastroplasty are the restrictive procedures. The nutrient diverting therapies are endobarrier, magnetic anastomosis, and mucosal resurfacing. Now, these are the panoply of intragastric balloons which are available. Balloons were first approved by US FDA in 1985. There are 2 types of balloons, the fluid-filled balloons and the gas-filled balloon. Fluid-filled balloons produce greater weight loss compared to gas-filled balloons, but they produce less nausea and vomiting compared. So gas-filled balloons produce more nausea. Now, this is the data on the Orbera balloon. You can inject 400 to 700 ml saline. The total weight loss is to the tune of 10.5%. Orbera balloon is endoscopically inserted, usually for 6 months. Nausea, vomiting may occur in the initial period. This is the data on the Ellipse balloon. Is a soluble balloon. Again, similar amount of fluid can be injected. The excess weight loss is 37.2% at 24 weeks. Nausea, vomiting, of course, are the side effects in the early stages. And the Oberlin balloon is the most popular balloon which is used in our country in the bariatric centers. It can be utilized as an OPD procedure. The patient swallows the balloon under fluoroscopy, and then gas or air can be injected. The total weight loss is 6.81%. And it does produce some nausea and vomiting. Endoscopic sleeve gastroplasty is again a magnificent procedure. These are the 3 types of endoscopic procedure instruments. I'm not going to talk about them. And this is what we achieve by endoscopic gastroplasty. the stomach is reduced in the form of a sleeve, which offers great weight loss. And this is a radionuclide study. You can see even at the end of 3 months, at 240 minutes, there's food retained in the stomach. Normally it is less than 5%, but here substantial amount of food is still there in the stomach. What is the effect on the comorbidities with endoscopic sleeve gastroplasty? This is an Indian data. Type 2 diabetes remission in 76%, hypertension 91%, and OSA almost to the tune of 100%. And this is again an Indian data for endoscopic sleeve gastroplasty. You can see 53 patients, BMI average 34, mean duration of procedure 68 minutes, and the average total weight loss at the end of 1 year, you can see, is roughly 20%. So good weight loss. And the MERIT trial, which was carried out with sleeve gastroplasty, has also come out to be positive. And you can see the excess weight loss is to the tune of 14.92% at 12 months, which is substantial. What are the nutrient diverting therapies in very brief? The first is an endo barrier, which basically involves placing an impermeable barrier between the food and the absorptive mucosa and the foregut. We have the mucosal resurfacing. Duodenal mucosa resurface is a single minimally invasive endoscopic procedure that involves circumferential hypothermic ablation of the duodenal mucosa, resulting in subsequent regeneration of the mucosa. And before ablation, of course, the mucosa is filled with saline to protect the outer layers of the duodenum. And this is a magnetic anastomosis, which is also very fascinating. Bariatric surgery is the most effective way to lose weight. Bariatric surgery enhances weight loss in obese people who have not achieved long-term success with other weight loss attempts. And these are the three bigs in bariatric surgery: gastric bypass, duodenal switch, and gastric bending. What is gastric bypass? Small gastric pouch with bypass of the small portion of intestine is restrictive as well as malabsorptive. Duodenal switch, in this, partial gastrectomy is done with anastomosis of the stomach to the distal ileum, which is a biliopancreatic diversion, restrictive malabsorptive. And gastric bend is a simple procedure, is only restrict, and the bending is adjustable. Duodenal switch produces the greatest weight loss, followed by the gastric bypass, followed by the gastric bending. So gastric bending produces least weight and also produces least side effect, whereas more problems with duodenal switch, but more weight loss compared to the gastric bypass. Obesity produces 3 to 10 years loss in life expectancy. Bariatric surgery produces 40 to 45% reduction in heart rate complications for patients of diabetes and obesity. And the benefits of sustained weight loss through bariatric surgery include long-term remission of type 2 diabetes, improved cardiovascular health, relief of depression, virtually eliminates obstructive sleep apnea, joint pain relief, improved fertility, elevate other medical conditions, greatly improves the quality of life. Whatever is the bariatric procedure, you can see there is substantial weight loss. You can see gastric bending before, after procedure, sleeve gastroplasty before, after, gastric bypass, or doing there's substantial weight loss. This lady, poorly controlled diabetes with insulin plus hypertension, becomes euglycemic in 2 weeks following sleeve gastroplasty. This is gastric bypass procedure, diabetes since 7 years, and hypertension, immediate diabetes resolution. And look at the great change in the appearance of this young lady following sleeve gastroplasty, hyperinsulinemia, impaired GTT, strong family history, diabetes, post-gastric, post-surgery, dramatic improvement. And at last, we have the robotic bariatric surgery. The most recent innovation in bariatric surgery is the introduction of robotic surgery. Robotic surgery for obesity has definite advantages of conventional laparoscopic surgery due to its 3D vision, precise unit multi-range instrument that add more safety to the patient, but it's very expensive and a very long learning curve. This shows the comparison of the various modalities of treatment. The effects of endoscopic bariatric procedures for weight loss is greater than drugs, but lower than bariatric surgery. But because endoscopic bariatric procedures are comparatively safe, there's a shift towards endoscopic bariatric procedure first, and if needed, later on as a stage 2, bariatric procedures can be done by surgery. Fecal microbiota implantation is still in the process of evolution. So this is the shape of things we are witnessing at the present state of time, and our desire is to reverse this change. Thank you very much for your kind attention.
Thank you, sir. Thank you for excellent lecture. And I feel whenever I will hear you, I am pleased to hear you because the 3 reason is there. You are always giving the excellent oration, and it is informative for the all the PG students as well as to the consultants also. As I am working in this center where highest number of surgery, robotic surgery, particularly for the weight loss is there. And you have termed nicely diabetes with the obesity, and our institute is having this highest number of sleeve, robotic, and this swallow. All the things are going on. The only thing I have to ask, because you have narrated all these things, one question for you, sir. Do you think any role of intermittent fasting in weight loss?
See, this will only provide temporary relief. As we said, obesity only goes in remission unless you persistently follow lifestyle modifications, which is very difficult for most of us. So if your weight loss is too much, your BMI is increased, your waistline is increased, you should can get an endoscopic bariatric procedure. But in times to come, when this semaglutide becomes available in India, when tirzepatide gets approved and available in CagriSema, the first option would be anti-obesity drugs rather than bariatric procedure, because most of the patients are reluctant to have even an endoscopic bariatric procedures and more reluctant to have surgical bariatric procedures. So we are keenly awaiting these drugs. Semaglutide is already approved and going to be available in India in the next 6 months, because the weight loss with semaglutide is 15 to 17 kg, which is just like a sleeve gastroplasty.
Dr. Manoria, hello. You can go. Yeah.
Yes, sir. One question. After surgery, every surgery, what we are getting after 2 years, now every patient is having the deficiency of some nutrients. So they are required for that. So do you think they should be given regular nutrients, particularly the minor nutrients, or if we are giving these oral drugs, that will also require these trace elements, the minerals like supplementation?
See, all bariatric centers, as you have an experience, they have dedicated dietitians and physicians who look after all these, because it has to be a dedicated, all malabsorptive procedures, restrict produces all these deficiencies. So there's a dedicated program running in all bariatric centers. They will look after all these deficiencies. Deficiencies, as you said, are inevitable once you are doing these restrictive procedures, or when a combined restrictive plus a malabsorptive procedure. So usually they have fixed protocols and they look after all these problems.
Thank you, sir. Thank you.
So thanks a lot, sir, for excellent talk. And in the youngsters and the adolescents also, this problem is increasing day by day. So your topic was very much important. At what age we can indicate this surgery, sir?
See, usually they do for adults, but now it is also being tried for younger patients. Endoscopic bariatric procedures can be done for younger, and the balloon, which is a soluble balloon, can be done as an obesity procedure at any age, because it can be taken out if there's problem. Usually nausea vomiting occurs in the first few days. So endoscopically inserted balloons is a good option for young persons. Sleeve gastroplasty can also be done. Those who are experts in this field, the morbidity and mortality are very minimal. And if care is not taken for this childhood obesity, this will run into diabetes, childhood diabetes, coronary artery disease, and the future of the young generation will be destroyed. So at national level, prevention of obesity and childhood diabetes and diabetes should be initiated. Otherwise, it is going to create serious problems in times to come.
Yeah, sir. Thank you, sir. Over to Parashar, sir.
What is the normal visceral fat area on CT or MRI, and what is the weight and set distribution ratio? Visceral fat as well as the subcutaneous fat ratio.
Normal visceral fat area is less than 130, and the subcutaneous fat area is 136 or less than, plus minus 10, this way or that way, and the ratio is 0.80.
I want to clarify the lecture given by Dr. Sarin regarding the metabolic obesity. Can you clarify more? There are 3 points. What is the normal weight obesity? What is the metabolically unhealthy obesity? And what is the metabolically healthy obesity? I want to know about these things.
You may be obese.
Normal.
Yes, you may be obese and yet may be metabolically healthy. So obesity is not invariably associated with metabolic obesity, although it is commonly. The second is your weight may be normal and yet you may be metabolically unhealthy, as shown by the Indian data. Indians have a tendency to higher visceral fat, so that you may have normal BMI and yet your visceral fat may be higher. And that's why we call this thin fat Indians, or normal weight or normal BMI metabolic obesity. So usually obesity is metabolically unhealthy, but those who are doing regular exercise, they will lose their visceral fat, although their weight may be high. So these are the 3 subsets.
All right. Thank you very much, Dr. Manoria, for a very informative and analytic talk.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.